paid program. WFEA is not responsible and accepts no liability for any of its content. The opinions, views, and advice expressed during the show are solely those of its participants and not those of WFEA, its advertisers, or management, and should be used as such, as every individual situation is different.
It's time for On Call with Minuteman Health, bringing you an hour discussion with New Hampshire physicians and healthcare experts on topics ranging from specific medical conditions to our changing medical system. On Call with Minuteman Health, helping you understand healthcare. And now, here's your host, Scott Colby.
Good morning, folks, and welcome to On Call with Minuteman Health. I'm your host, Scott Colby, and in the studio with me this morning is Dr. Myles Keroack of Elliot Gastroenterology at River's Edge. Good morning, Dr. Keroack, and welcome to the show.
Good morning, Scott. Thank you very much for having me.
Oh, it's great to have you here. Thank you. So Dr. Keroack is in this morning to discuss colon cancer awareness. We have touched on this subject a couple times since we launched the show 2 years ago, but it's a very important topic, and we can't get enough of it. So once again, Dr. Keroack, it's great to have you here. So before we jump in, I'd like to introduce the listeners to you a little more formally. So Dr. Myles Keroack attended medical school at Tufts University School of Medicine in Boston, completed his residency at the UMass Medical Center in Worcester, is fellowship trained through Lahey Health, is board certified in internal medicine and board certified in gastroenterology, and once again practices here in Manchester at Elliot Gastroenterology at River's Edge. How'd I do?
Hey, perfect.
I nailed it.
Yes.
Nice, nice. So, Dr. Keroack, I appreciate your flexibility, and for the listeners' benefit, March was actually Colon Cancer Awareness Month, and you and I had scheduled to come on, but I had a personal matter come up very suddenly, and we had to punt to April. So thank you for your flexibility. I really appreciate that.
Oh, no problem. It's a very important topic, important issue that we really wanted to talk about and needs to be spread out to the general public.
Great. So before we get in, it's always helpful, I think, for the listeners to better relate, if you will, to the guest. And one of the ways to relate to the guest is to understand why you chose this particular field of medicine. So could you share your story with us?
Sure. I mean, as everybody knows, it's a very glamorous field with the things that we do.
Very glamorous.
But usually when people are going through their medical training, you find things that you like and things that you don't like, and often you find a mentor along the way. And for me, gastroenterology was sort of the most interesting part of medical school and medical training when we did our anatomy and physiology. And I was lucky I had a mentor at New England Medical Center, where Tufts is, who allowed me to be in touch with a general surgeon. And in my first year of medical school, I actually had the chance to get into surgery. And he actually specialized in colon rectal surgery. And unfortunately, my family was touched by colon cancer, too. So I always had sort of a soft spot in my heart to want to pursue that and chase that down. And as the years went by through my training, I found that those were the most interesting cases to me, the problems that came up in gastroenterology. And so you sort of it chooses you as opposed to you choosing it. And like I said, often finding mentors that you can identify with and being similar to you is the reason why most people end up in the specialty that they're in.
Great. Well, thank you for sharing that, Dr. Keroack. I appreciate that. And what I'd like to do at this point is I wouldn't like to invite our listeners to call in and ask any questions they might have about colon health or colon cancer. And that number is 603-669-1370. So as a refresher, we're going to focus today, obviously, on the lower GI, the lower gastrointestinal tract. And I was wondering if you could bring us through the anatomy lesson. I find that this is really important to help reorient all of us to the anatomy and the parts of the body that we're talking about. So maybe, Dr. Keroack, we could start with the stomach and move south.
Sure. I mean, as we all know, when you eat your food, it starts in your mouth and then goes down through the esophagus, which is a tube that connects your mouth to the stomach. And the stomach is where digestion starts. It produces acid and helps break down the food that's in your stomach. Once it leaves the stomach, more processing takes place. The acid and the movement of the stomach will break the particles into very, very small particles and create it and turn it into a liquid. And then there will be secretion of enzymes and bile. Bile comes from the liver, and the enzymes come from the pancreas to help digest the food even more. It becomes basically sort of a molecular, very, very small particle soup that is then absorbed by the small intestine.
Okay, so do the enzymes in the bile, are those introduced in the small intestine, or are those introduced in the stomach?
In the very beginning of the small intestine.
Okay.
Once it leaves the stomach, then the enzymes will be introduced to help break down the food even more.
Okay.
When it's broken down into its complete elements of proteins and fats and carbohydrates, then it is finally absorbed through the small bowel. And the small bowel is about 20 feet long.
Okay.
But because of all the curves and undulations and these little projections we call villi, they sort of look like what a shag carpet used to look like.
Oh, right.
The surface area to absorb food is about the size of a tennis court. So if you're
wow.
standing in the middle of a tennis court, your small bowel is about the size of that to help absorb all your food.
Wow. That's a great visual, Dr. Keroack. And it's not an icky visual.
No, exactly. We're not there yet. Yeah.
We'll get there.
Exactly.
Fasten your seatbelts, listeners.
Different parts of the small intestine are responsible for absorbing different things. The upper part mostly, nutrients and vitamins, and as things get lower, the very last part of the small intestine is responsible for a particular vitamin B12, which is important.
Okay.
So now once it's finally traveled that 20-foot path, it finally gets to the colon, which is the part that we're most concerned about today. And the colon is interesting. It's about 3.5 feet long,
okay.
but its main job is to reabsorb water. About 9 liters of fluid dumps into the colon every day. So if you didn't have your colon, you'd probably spend most of the day in the bathroom. You wouldn't really have much of a chance.
9 liters?
9 liters of fluid.
So that's 3.5 of those 2-liter bottles. So just to give the visual. I mean, the math is correct. I know it is.
Yeah.
But just to give the visual, that's a lot.
That's a lot of fluid. And there is a certain disease that people get called cholera. You'll hear it a lot in refugee camps and things like that. And the bacteria that causes cholera actually blocks that ability to absorb the water. So these poor people basically have 9 to 10 liters of diarrhea every single day.
Oh,
so it's terrible. That's why they die.
Right.
That's why they die. That's a whole other discussion we could have. But at this point, the colon's job is to reabsorb water.
Okay.
So it takes that 9 liters of fluid and turns it into about 250 or 500 cc's of formed bowel movement, basically, so that we can have chance to go play golf and enjoy the day.
So could I step back just a minute on the water absorption?
Yes.
So the colon absorbs 9 liters a day. That must be the primary organ responsible for keeping you hydrated.
Yeah, the small bowel absorbs water too, but because there's so much water that gets introduced into the colon, it is one of the main things that keeps you hydrated. That is true.
And so I want to start at the very beginning, even though I said we were going to start at the stomach.
Mm-hmm.
When I take a drink of water when I'm really thirsty,
mm-hmm.
it feels like it's being absorbed in my mouth. And,
right.
And you're laughing at me, and you're telling me, no, not really, Scott, but maybe a little bit?
Probably some is. I'm sure some is. I mean, some water does get absorbed through the surfaces of those, what they call mucous membranes, which is your lips and mouth and tongue, that sort of thing.
Okay. But it's really the colon that absorbs the vast amount.
The majority of it.
Okay.
That's true.
Very good. And then it reduces down to stool about 250 to 500 cc's.
Mm-hmm. For most people, yes.
For most people. Okay, great. Well, thank you very much for that. And, Heather, it sounds like we're coming up on break. Thank you. I wasn't paying attention, folks. So, Dr. Keroack, good place to stop. And when we come back, why don't we talk a little bit more about some of the do's and don'ts as it relates to colon health, and then we're going to ultimately get into colonoscopy and proper screenings. Dr. Myles Keroack of Elliot Gastroenterology at River's Edge is here this morning to discuss colon cancer awareness. 603-669-1370 is the number. Again, 603-669-1370. We'll be right back.
People are finally doing something about the rising cost of their health insurance. They're switching to Minuteman Health. Minuteman Health could save you $1,000 to $5,100 a year on your premiums. Enroll at MinutemanHealth.org. Savings based on healthcare.gov comparison of the lowest cost 2016 silver plans for all carriers in 03215 for a family of 4, 2 adults age 40 and 2 children under 21, all non-smokers. Provider networks, benefits, and cost-sharing amounts vary.
St. Joseph Hospital now gives you more room to relax inside our new wide-bore MRI, used to help diagnose possible injury or illness. Patients who might find conventional closed MRIs difficult to tolerate no longer have to sacrifice comfort for the quality of their images. St. Joseph Hospital's new MRI unit will provide you with a faster, quieter, and more comfortable MRI exam without that closed-in feeling. We offer appointments 7 days a week for added convenience, and we promise to provide your exam results as quickly as possible. Top quality imaging for precision diagnosis. Expert care in a stress-free, patient-friendly environment. the latest innovations and technologies. It's just what you'd expect from St. Joseph Hospital. To learn more about our new wide-bore MRI, visit us at stjosephhospital.com. That's stjosephhospital.com.
When your diagnosis includes the word cancer, you want your care to be the best possible. At New Hampshire Oncology Hematology, their mission is to provide expert and compassionate care for adults with cancer and blood diseases. Their providers are committed to their patients and their fight. All members of their staff value honesty, teamwork, and communication with patients, their families, and all members of the care team. You and your family will always be treated with dignity and respect at New Hampshire Oncology Hematology. To learn more about their cutting-edge care close to home, visit NHOH.com.
You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby. And in the studio with me this morning is Dr. Myles Keroack of Elliot Gastroenterology at River's Edge here in Manchester. Dr. Keroack, once again, thanks so much for joining us.
Oh, thank you again, Scott.
It's great. So Dr. Keroack is here to discuss colon cancer awareness, and the number, if you have any questions, is 603-669-1370. Again, 603-669-1370. So Dr. Keroack, many of us know that we have to have a colonoscopy, and we have a sense as to when we need to start. But I was wondering if you could talk to us about colonoscopy, when it really became standard of care, what happened, what prompted medicine to move us in that direction, and then describe the procedure for us again.
Sure. It wasn't always this way. I mean, when I started my career back in the early 90s, colonoscopy was not the standard screening test. We used to do what they call flexible sigmoidoscopy, or even a rigid scope, which was even worse. But it was one of those things where we had very few limited exams that were used as screening tests because there wasn't a heightened awareness of screening for colon cancer at that point. Unfortunately, a lot of people just sort of waited until they got symptoms. Then they came in and saw their doctor, and by then it was a big problem.
Right.
So it really happened in the late 90s when Katie Couric's husband died from colon cancer, which is interesting because there were two people in the Boston area that had colon cancer. The coach of the Celtics had it in the 80s, and President Ronald Reagan had it in the 80s as well. So you'd think that maybe it would have caught on at that point,
right? But
it just didn't get enough traction at that point.
Okay.
Katie Couric's husband was, I think, 42 when he died, and again, very young, and didn't have any, had symptoms, and then it was too late by that time.
Right.
So
and we'll get into the signs and symptoms and all that in a few minutes.
And so she took it upon herself as a crusade to bring colon cancer screening to the forefront so she could really save lives. I mean, it became aware that, colon cancer is the third most common cancer in the country for men and women, and it's actually the second leading cause of cancer deaths. And it's been that way for a long, long time. 100,000 cases every year that show up for colon cancer across the country. So she was on TV. She spoke to the docs who were on TV for the news shows. She went before Congress. And finally, in the late 90s, might have been 99, 2000, or maybe just before that, maybe 97. But at any rate, Medicare began covering colonoscopy as a screening test. And once Medicare starts covering it, then the rest of the insurance carriers do as well.
Exactly.
They made a good enough case to prove that it was actually cost-effective. Between all the screening tests that we have now, colonoscopy is actually considered a cost-effective test because we do it infrequently, and the number of polyps that we find and lives that we save make a huge impact.
And so, even though colon cancer is the third most common cause of cancer deaths in the country, have we seen improvements in treatment and life expectancy? Have we seen the number of cases go down because of precancerous lesions being removed?
Yeah, it's great that you bring that up because there was a study within the last few years that showed that from over the last 10 to 15 years or even 20 years back, there has been an almost 30% decrease in the rate of colon cancer.
Okay,
which makes it
very encouraging.
It's unbelievable because originally in the the 60s, 70s, and early 80s, the rate of colon cancer in the general public was somewhere around 8%, maybe almost 9% in some studies, and it's dropped down to around 5 or 6% at this point.
Wow, that's very encouraging.
So we've made huge impacts, and it has become almost part of the standard discussion that people have. There are so many people deciding to get colonoscopy, and if they come before they have any symptoms, we can find the polyps when they're benign, and even if, unfortunately, we find a tumor, often it's in a very early stage, and then people can have surgery and be saved from that standpoint.
Right.
So it really behooves people to be aware of the seriousness of the condition and to come and have the procedure done, and it really has made a huge impact.
So before we went on the air this morning, you and I were talking about the age at which you should have a colonoscopy, and again, I'm gonna credit our listeners with being faithful to the show. Thanks, folks. But they probably know that age 50 is the standard if you don't have a history or whatever. But we think of age 50. Why age 50, Dr. Keroack?
Well, they looked at the curves at when colon cancer starts to show up in the general public, and it's usually somewhere in the late 40s. You'll start seeing the curve go up. But I think there were years of discussion and public policy discussions that took place to try to figure out what is the most cost-effective way to start screening as many people as possible and to catch as many people as possible and get the most number of polyps and, I guess, the best bang for your buck from that standpoint. And 50 seems to be the place that is the best place to start. There are people that have a family history that's significant, and they really need to start sooner. Generally, it's somewhere in the mid-40s, or if they had someone unfortunate enough to be very young, say they were 42, the standard is about 10 years before that person starts. Before 10 years, they should get started doing colonoscopy before the time that person had colon cancer.
Wow. So in the case of going back to Katie Keroack, you said her husband was 42. So his children should start at 32.
That's what the recommendations are.
Wow.
Because the thought is that from the science, a small polyp that we find, it takes almost 10 years for it to turn into a colon cancer.
Okay. All right. Well, very good. Very, very interesting. So in a few minutes, I'd like to get into the risk factors, and then I'd like to talk about signs and symptoms of colon cancer. But before we do, could you walk us through a colonoscopy? Walk us through the prep.
Sure.
Walk us through how you coach your patients and the advancements that have been made. Now, a couple of years ago, so listeners know I'm 52. A couple of years ago, I had my colonoscopy. Yay, I was good.
Good for you.
I'm on the 10-year plan.
That's good.
Couple polyps, and my wife's like, and I'm like, relax, wait for the pathology to come back, and sure enough, came back clean, and there you go.
Good.
Wasn't that big of a deal for me, and we're all different, but walk us through it.
And I would say for most people, it's not that big a deal. And
wasn't even embarrassing. I thought it would be.
Yeah, and I think that's because it's become part of the standard. I mean, if you turn the clock back too far, there was a lot of self-consciousness about it. But now people talk about it at, cocktail parties and things. It seems kind of crazy, but it has become a pretty regular thing for people to do. The prep is clearly the hardest part of the procedure, and they've been trying to fix the prep as best as possible. Though several years ago, they came out with some preps that were in a pill form, but those had problems with renal failure and blood chemistry changes. Some people had seizures.
Oh, goodness.
So a lot of those are basically off the market. The only prep that's safe and works effectively is, unfortunately, the big gallon jug of fluid that has electrolytes in it that kind of wash everything out. And that goes back to the colon's ability to absorb water, right?
Yep.
You have to overwhelm that ability of the colon to absorb all that water. So the best prep that we've come up with at this point that has been studied is when they cut the prep in half. You do half the night before and half the morning of the procedure. And people seem to be able to tolerate that better. Yep. And once you get through the prep well enough so that basically water is coming out the other end and everything is cleaned out, you can actually see well enough that the colon is not like you'd imagine it to be, such that if you looked in your mouth in the mirror, that's basically what it looks like. It's completely cleaned out, and we can find small polyps very, very easily if the preparation is good. So the key is getting a good preparation to have a good, thorough exam.
So in a minute, I'd like you to give us a visual on what a polyp looks like, and I'm assuming at various stages they look a little bit differently. But as you go into the colon, Dr. Keroack, how far do you actually travel?
Yeah, we go all the way to the opposite end, to where the colon begins, where it meets the small intestine.
3.5 feet?
3.5 feet, all the way to the end, because we got to find polyps throughout the colon. They can be basically anywhere. Polyps can be any size. They usually start on the order of millimeters, and they basically look like a wart on your skin. So it doesn't look like the surrounding tissue. It has sort of a bumpy texture to it. It may be a little more red. So we're usually pretty good at finding them. There are some polyps that are harder to find. They're flat. They're right up against the surface of the colon, and their color is very similar. So they're a little more difficult. So you you really have to take your time and pay attention to what's going on from that standpoint.
And maybe there's no good answer to this question, but I'll ask it anyway. Why are some more like warts and bumpy, and some are flat and red and a little more hard to find? Does that mean they're a different, what's the word I'm looking for? Are they a different polyp? Or
there's two main families of polyps, one called hyperplastic, which are actually not precancerous.
Okay.
So that is not an increased risk for colon cancer. And the ones that are called adenomas, those are actually precancerous polyps. There's another family that is flatter and the color is similar. For its technical term, it's called a serrated adenoma. That's only for me to know. But it becomes a little more difficult to find. And that's why it's not a procedure you should rush through. And it really should be done by people who are highly trained to do colonoscopy. Okay. And I think it's that's one of the things that's very, very important to make sure that people take their time and look for these types of polyps, because they can be missed, and you really don't want to miss these things.
Right. And so about how long does it take to do a colonoscopy?
The standard, from start to finish, probably somewhere between 20 and 25 minutes to do the procedure.
Okay.
It all depends on how long it takes to get to the other side. Some people are more difficult than others. Some people have had surgery that makes it a little more challenging. But basically the key is on your way back. You have to really slowly take your time. Studies say that it should be at least 6 minutes or more for you to find polyps, to have your highest success of finding polyps.
Okay. And Dr. Keroack, we have a couple minutes before we go on break. You're in the colon, you're examining it, you described how clean it is, and you have a visual of the walls. When you remove a polyp, is there a blood supply to the polyp? What happens, and how come I didn't feel anything? Yeah,
there is a blood supply depending on the size of the polyp. Some of the larger polyps have big blood vessels in them. Most of the smaller ones don't. Okay. The nerves for pain in the colon are on the outside, so the thing that causes discomfort during a colonoscopy is the air insufflation, which stretches the colon, or pushing on the walls of the colon as you go around the corners. Removing polyps on the inside, there's no nerve endings on the inside, so you feel no pain when you're doing that. Okay. And we often use electrocautery for larger polyps to remove them. And an advance that happened in the last few years is we have these small metal clips that came out of laparoscopic surgery. Okay. So we put the clips on the polypectomy site so that it's less likely to bleed going forward.
So the clip stays in the colon then?
For about a month.
And it just passes naturally?
Yep, falls off on its own.
Okay. All right, very good. And then when you're done, what in your unscientific statistic I'm asking for, in your practice, what percentage of the patients do you normally take polyps out and send them to pathology?
It's somewhere between 20 and 25%.
Okay.
We're part of the New Hampshire Colonoscopy Registry, which is a study out through Dartmouth, and they're involved in all the sites around the state. And the accepted, what they call adenoma detection rate, is anything over 25%. Okay. So we find polyps often, but they're not all precancerous, and they're certainly not all malignant. Okay.
Well, Dr. Keroack, we are going to be bumping up against breaks, so this is a good place to stop. When we come back, let's talk about risk factors, incidence of cancer, signs and symptoms, and then ultimately we'll get into some treatment. Dr. Myles Keroack of Elliot Gastroenterology at River's Edge is here this morning to discuss colon cancer awareness. 603-669-1370 is the number. Again, 603-669-1370. We'll be right back.
We didn't start with the idea of a new facility, but as ideas evolved, they led to the Elliot at River's Edge.
Elliot Orthopedic Surgical Specialists is a group of highly skilled doctors.
We provide comprehensive diagnostic testing for sports injuries and other mishaps.
Whether we repair, replace, or reconstruct hips, shoulders, hands, or knees,
our doctors will diagnose and begin treatment plans right away.
I'm Dr. Marilyn Soul.
I'm Dr. Jonathan Mack.
I'm Dr. Paul Scavetta.
I'm Dr. Martin Ross.
I'm Dr. Rob Parisian. Our complete orthopedic team is ready to treat you.
The Elliot at River's Edge is now home to the most advanced ambulatory health care in New Hampshire. It's also comforting to know that Elliot Surgical Specialists and the nationally acclaimed Elliot One Day Surgery Center are at the Elliot at River's Edge off Queen City Avenue. Elliot at River's Edge. We're ready to get you back to your active life. For more information, go to ElliotRiversEdge.com.
At Catholic Medical Center, we believe that excellence in healthcare and personal respect for our patients go hand in hand. From our primary care and laboratory services, the Mom's Place, to our minimally invasive robotic surgery, CMC meets your every healthcare need. Our expert specialists and caring medical staff are dedicated to being your lifelong partners in good health. CMC, leading the way with heart. Find out more at CatholicMedicalCenter.org.
When you have digestive problems, you need to turn to a gastroenterologist who listens and responds, an experienced doctor who knows the field and can effectively diagnose and treat your needs. New Hampshire Gastroenterology in Bedford is now opening a new office in Nashua. You'll receive the same superior and compassionate care from their dedicated team of trained gastroenterology professionals who give you the individualized care that you deserve. Call New Hampshire Gastroenterology today at 625-5744 or visit nhgastro.com for their 2 locations in Bedford or Nashua. You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby. And in the studio with me this morning is Dr. Myles Keroack of Elliot Gastroenterology at River's Edge. Good morning, Dr. Keroack, and once again, thank you so much for joining me.
No, again, thank you, Scott.
So here we are halfway through the show, and I always say this, the listeners are like, oh, here he goes again, but it flies, doesn't it?
It goes very, very quickly when you get talking.
It does. And so at any point that you want to jump in and cover a topic that we might be glossing over or something jumps into your head, interrupt me. It's your show, Dr. Keroack. So when we went on break, we discussed colonoscopy, the procedure, and I'd like to go and move over now to colon cancer.
Okay.
Before we get into signs and symptoms, though, I'd like to talk about risk factors, those that are avoidable risk factors and those that might not be avoidable risk factors.
Okay. It's never been completely clear what causes colon cancer, but certainly there have been studies that have linked certain poor behaviors that tend to create colon cancer.
Mm-hmm.
It looks like red meat and fatty foods appears to increase the risk of colon cancer in most people. Smoking appears to be a risk for colon cancer as well.
Mm-hmm.
And there have been studies linking obesity to colon cancer. So, people who eat a proper diet and exercise and try to stay fit and don't smoke probably decrease their risk for colon cancer. So that's probably the best we can do from that standpoint. There were some studies looking at high amounts of fiber in the diet, but that was never 100% clear. It probably was that those people were eating good foods and not eating the bad foods that was more likely to help with the risk factors.
So, Dr. Keroack, when you look at the things that you should try to avoid or the things that you should try to do properly, the common thread that I see in those, and I'm not a scientist, you are, so please reel me in, is blood flow. Is there anything to that? I mean, when you talk about exercise, when you talk about not smoking, when you talk about eating properly.
It's interesting. I haven't thought of it that way. I'm not sure that they've narrowed it down to that degree. The part of the thought is that the lining of the colon actually survives off of the stool. Believe it or not, the cells of the lining of the colon use the stool as fuel. So if the content of the stool contains things that are noxious or toxic to the lining of the bowel, that may be more likely the process that's causing the problem.
Interesting. Well, thank you very much for that. So those are lifestyle or behavioral factors that can lead to colon cancer, but there are also genetic factors, right?
Absolutely. There are some well marked out genetic syndromes. Ever since they've been able to map out the human genome, it's even become more aware of the number of genes that can cause colon cancer. And there are certain familial syndromes that cause large numbers of polyps in the colon. Most of these polyps are pre-malignant or even more malignant when they first show up. So it's basically describing the fact that the cell life cycle in the colon is really abnormal because of these genetic factors. It's the minority of cases. It's the ones we all always read about and hear about and talk about, but the vast majority of colon cancer is what we call sporadic or random events.
Okay. And when you talk about a genetic predisposition, in one of the earlier segments that we did this morning, you had mentioned that for children of a parent who is diagnosed with colon cancer, they'll want to have their first colonoscopy 10 years in advance of the age that their parent was diagnosed. Is that correct?
That's right. That's what the recommendation is.
And is that the closest link, as best we know today, is parent to child? Or is there grandparent grandparent to grandchild correlation, or is it really parent to child?
The highest risk factor is parent to child.
Okay.
If there is a grandparent that had it, they call it a second-degree relative, so it's a little less of a risk, but it's still not a zero risk. When you talk about cousins and aunts and uncles, then it gets a little bit softer.
Got it.
When you talk to geneticists who study various forms of cancer syndromes, they'll look at an entire family tree and see what types of cancer are in that family tree, and there are other cancers that are traveling the same genetic syndromes as colon cancer. So if you start having, family members that have had ovarian or uterine cancer, and then there's a stomach cancer and the pancreatic cancer, you start getting a little more concerned, like, well, maybe there's a bad gene here somewhere.
Okay. So colon cancer symptoms, is it considered a silent killer?
I would say it is, especially in its early phase. I mean, there are people that we see who come in for a screening test with no symptoms, no problems, and we do find an early stage tumor. Mm-hmm. So if those people waited and didn't have any symptoms until it was too late, then, again, they often have an advanced disease and their prognosis is much poorer. So early on in the game, the people say, what are the symptoms of colon cancer? You could say nothing. There are many people that have small tumors that don't have any symptoms at all. If you started having symptoms that were worrisome, the ones to be concerned about would be bleeding, obviously, bleeding through the rectum, abdominal pain, sort of anywhere in the abdomen, because the colon can be basically anywhere in your abdomen. Changes in people's bowel habits, like if your entire life you had constipation and suddenly you had frequent loose bowel movements, you'd wonder what's going on from that standpoint. Or the other way around, if I always went 3 times a day and all of a sudden I'm going once every 2 or 3 days, you'd be concerned about that too. So anything that's a
really
dramatic
changes.
Yeah, anything that's a dramatic change, you'd be concerned about that.
Right. And when you say bleeding or blood in the stool, we don't want people to hit the panic button either, right? Because there are other reasons that you can have blood in your stool, but you just have to be. You have to be deliberate in your approach. See your doctor, right, and get tested.
It's funny, the vast majority of people who have rectal bleeding, they come to see us for a colonoscopy. Most of them have something simple, like hemorrhoids, that's causing the bleeding.
Right.
But what I tell patients is that, even though my suspicion is such that you probably have hemorrhoids, I need proof. I need to prove that to you and prove that to everybody that this bleeding is not from anything serious. So if you go with a symptom of rectal bleeding, you have a normal colonoscopy, and then 2 weeks later you have rectal bleeding again, you don't have colon cancer because it grows so slowly. Those things just don't happen that quickly.
Right.
You can actually be rest assured that bleeding is not from anything serious.
And on the abdominal pain, Dr. Keroack, I'm assuming that you're talking about severe abdominal pain.
It can be more mild, so kind of a cramping discomfort.
It can be. Okay.
Those can be the early stages that, you have cramps or discomfort associated with your bowel habits. Unfortunately, those symptoms, again, mimic more benign conditions, too. We see a very common condition called irritability of the bowel, where people get irregular bowel habits, cramping-type abdominal pain, and it scares the patients, but it is a benign condition. But again, it comes down to the issue of proof. You need proof that is the correct diagnosis, and make sure that it is not masquerading as something more serious like colon cancer.
Right. Okay. So there may be listeners out there who are battling this or have a family member who is battling colon cancer, and so we always want to be sensitive. But let's say now you're given that diagnosis that nobody wants to get, and I'd like to be able to walk through a couple different treatment regimens. Some maybe a treatment for an individual who's diagnosed early on, and it's staged very, very low.
Okay.
And then somebody who maybe is diagnosed a little later and it's a more advanced cancer. And what does the treatment look like? So if you could.
So when I unfortunately see people who have cancer, my way of dealing with it is I start the process as soon as I know what it is.
Okay.
They need to be staged in a way to know, is the cancer localized just to the bowel or has it moved somewhere else? That's why we often do CAT scan procedures to look inside the abdomen to make sure it's only in the colon.
And Dr. Keroack, when do you know? So somebody comes in for a colonoscopy, or they suspect something. How long does it take for pathology to come back?
Usually about a week,
okay.
Sometimes quicker, but it's somewhere between 5 and 7 days.
Okay.
I mean, most of us who've been in the business long enough can tell just by looking at a large, mass-type lesion that it's going to be a malignant tumor. But the way I tell people is that, my suspicion is very high. I have to wait for the final biopsies to come back. But, at this point, it looks very concerning to me.
Okay, so a week or so out, you call the patient back in.
Mm-hmm.
And
then we'll start the process of getting them to have a CAT scan done. And then they'll see a series of specialists. Often they'll see a surgeon and an oncologist, depending on the stage of the tumor. Now, colon cancer has different treatments depending on the location. If you divide the colon up into the colon and the rectum, rectal cancer has a different approach because it has two different blood supplies. And it looks like preoperative treatment is more favorable and people have a better outcome if they treat the patient before surgery with radiation and chemotherapy. Because of the location, they're trying to make it so that the surgery can reattach the patient and decrease the likelihood of them needing a colostomy.
So you're saying that surgery is called for in rectal cancer, but it's just when the surgery occurs.
There's usually a delay because the preoperative treatment improves the outcome and improves the prognosis. Now, other areas of the colon, often they go directly to surgery. They take the tumor out, and they also take a number of surrounding lymph nodes to make sure the tumor has not spread to any of the surrounding lymph nodes, because that would change the stage and determine whether they need any postoperative treatment. So in rectal cancer, you think about preoperative treatment. In other parts of the colon, you think about postoperative treatment if it has spread to any of the surrounding lymph nodes. And usually that's a combination of chemotherapy or maybe chemotherapy and radiation, depending on what they find.
So in rectal cancer, Dr. Keroack, how soon, so you begin the treatment of chemotherapy and radiation therapy, and how long does that treatment progress until you go to the surgical intervention?
It's usually a few months, and you'd think that would be very worrisome and scary for the patients. But in fact, the treatments are so effective, the tumor often shrinks during that treatment. So it's actually stopping the cancer in its tracks and actually making it go backwards, shrinks the tumor, makes it more favorable for them to have the surgery. So even though there's a delay from when you actually find the diagnosis till you have the surgery, things are actually getting better. So patients who are, should at least know that they're getting treated and things are improving instead of this waiting, because waiting really bothers patients. I don't blame them.
And we've had oncologists on the show. In fact, we're lining up another oncologist for later this spring to talk about cancer treatment. The chemotherapy, and I know you're not an oncologist, Dr. Keroack, but the chemotherapeutic agent that is used for rectal cancer, is that, I don't know how to describe it. I don't want to pretend to know more than I do, but is that like a sort of a broad spectrum, or is it a narrowly focused? Does it take its toll on the patient?
Not as much as it used to. Chemotherapy agents have changed a lot over the years, and I think the toxic effects have gotten better, and the effectiveness has gotten better. Certainly they would be able to speak more of it, but from listening to my patients, they don't seem as sick as they used to, say, 15 or 20 years ago.
So a few months of radiation, chemotherapy, the tumor has shrunk, and presumably the patient's feeling okay, but then they go in for surgery. And what is the recovery period for that kind of rectal surgery to follow up on the tumor?
If they can do a connection, a primary connection, usually people are in the hospital for 5 to 7 days, and then there'll be another probably 3 to 4 weeks of recovery at home from that standpoint.
So it's a major surgery.
Oh, yeah. It's a big deal.
Yeah. And on the so going a little deeper into the colon, you remove the tumor. You, well, not you, but the surgeon, the colorectal surgeon, removes the tumor, does some biopsy of the lymph nodes, because if it's up in the colon, chances are it might be a little more aggressive and it might want to spread.
You can't tell. Sometimes by looking at it, you'll think it may have spread somewhere, but it is only localized to the bowel, and that makes it a more favorable stage. Sometimes a smaller tumor may spread to the nodes sooner, and that makes it
So they just want to check. How long is the recovery? Is that about the same recovery as rectal surgery? Are you in 5 to 7 days, 3 to 4 weeks recovery?
Yep, it's about the same. It's like you said, it's a pretty good size abdominal surgery, so it takes a while for people to get better.
And then following that surgery, about how long would a patient expect to undergo chemotherapy or radiation?
I think it's on the order of 6 months or 12 months. It depends, I think, on what they find.
On where they're staged. Okay, very good. Well, Dr. Keroack, we're actually heading into break now. We're a little bit over, so I'd like to invite the listeners to call in with any questions they might have. 603-669-1370 is the number. Again, 603-669-1370. We'll be right back.
People are finally doing something about the rising cost of their health insurance. They're switching to Minuteman Health. Minuteman Health could save you $1,000 to $5,100 a year on your premiums. Enroll at MinutemanHealth.org. Savings based on healthcare.gov comparison of the lowest cost 2016 silver plans for all carriers in 03215 for a family of 4, 2 adults age 40 and 2 children under 21, all non-smokers. Provider networks, benefits, and cost-sharing amounts vary.
At Catholic Medical Center, we believe that excellence in healthcare and personal respect for our patients go hand in hand. From our primary care and laboratory services, the Mom's Place, to our minimally invasive robotic surgery, CMC meets your every healthcare need. Our expert specialists and caring medical staff are dedicated to being your lifelong partners in good health. CMC, leading the way with heart. Find out more at CatholicMedicalCenter.org.
We didn't start with the idea of a new facility, but as ideas evolved, they led to the Elliot at River's Edge.
I'm Dr. Joe Guanascia. There was a lot of talk about this being the right time for urgent care.
It's a perfect choice to treat illnesses, accidents, or injuries, or when your doctor's office is closed. I'm Dr. Kevin Rankins.
No one wants to take up time in an emergency room when others might need that time for life-threatening injuries.
Urgent care quickly gets you to a board-certified emergency doctor.
These days, making urgent care easily available and accessible means health care is less expensive for all of us.
Urgent care is a great option when you don't need an emergency room visit. I'm Joanne Waska-Cormier, LPN.
Urgent care at the Elliot at River's Edge. It's faster than an emergency room visit.
You're going to love our care.
Urgent care is open from 7 a.m. to 10 p.m. every day. No appointments necessary. Located right off Queen City Avenue at the Elliot at River's Edge. For more information, go to ElliotRiversEdge.com.
You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby, and joining me in the studio this morning is Dr. Myles Keroack of Elliot Gastroenterology at River's Edge. Dr. Keroack, this is our last segment. Once again, thanks so much for being here this morning.
And again, thank you, Scott.
It's great. So when we went on break, we went, as we were going into break, we were wrapping up a segment on the treatment of colon cancer, the treatment of rectal cancer, and typically what a patient can expect to see. If we could just step back a little bit and talk about the surgical interventions that might be called for, whether that be a colostomy or removal of part of the colon, what does that entail? And can you talk about some of the advancements and lifestyle improvements we've seen?
Right. I mean, one of the things that I didn't want to leave people thinking is that, once you've had surgery, your lives are going to change dramatically. Most people who have part of the colon removed, the colon is so good at doing its job, they lead perfectly normal lives and really don't even notice that that part of the colon is gone. Now, for people who have what we call low rectal cancer and actually do need a colostomy, it is a devastating thing for patients. It really scares them, and it's very concerning. But the technology in colostomy care and the way things are done now, those people lead perfectly normal lives, too. I mean, there are ways that they have low-profile colostomies. They still wear bathing suits, go to swimming, and it's very interesting that things have changed dramatically enough that a lot of times you can't even tell. The person sitting next to you may have a colostomy, and you wouldn't know.
And sometimes colostomies are only temporary, is that correct?
That's true. If they may need a temporary colostomy while they're undergoing that preoperative treatment like we talked about, and then it may not be an issue later.
Right, and it can be reversed. Good. Well, thank you for that. So let's move over now, and for the remainder of the show, if we could, let's talk about colon health, proper colon health, do's and don'ts, colon cleansing, these fads that people see, and help us better understand how we can achieve proper colon health.
Sure. I mean, one of the main things about cancer is prevention, right? We're trying to prevent, colon cancer. Yep. Colonoscopy is when you've already going to go find it, but that is a big part of the prevention.
Sure.
But there are certain things that have come to the forefront that people can do on a regular basis to decrease the risk of colon polyps. Big studies show that low doses of aspirin on a regular basis are not only good for your heart and strokes, but it actually helps decrease the risk of colon polyps. Mm-hmm. So that is certainly something to talk about your doctor, with your doctor about. There were some studies looking at folic acid. I'm not talking about high doses or mega doses of any particular vitamin, but a standard dose of folic acid on a regular basis. There have been some studies linking to decreased risk of colon polyps. High amounts of fiber, especially fresh fruits and vegetables in your diet, seems to keep your bowel activity regular. And again, maybe avoiding some of those toxins that are in the stool to help the colon lining be more healthy. One of the newest things that has come about, it's not new, but it's a heightened awareness lately, is probiotics, or the good bacteria that live in our system.
Okay.
Our GI system is full of bacteria, and they're actually supposed to be there. They help us digest food. They help us with a positive environment inside of our intestinal tract, and they certainly help the colon. There hasn't been any link with decreasing colon cancer, but you'd have to assume that that would be a more healthy environment.
Right.
Now, some of the fads you talk about, I always am very reluctant of any fad of any sort.
Sure.
People who have colon cleansing done or buy these things on TV that are supposed to, wash every bad thing out of your intestinal tract, I'd be very suspect of these things.
Well, you just said that the intestinal tract has good bacteria in it.
Correct.
If you're trying to play doctor and cleanse your colon, you might be flushing out really good things.
There's a good point in that. I mean, it's one of those things where if you're constantly washing out the interior of your intestinal tract, you may be washing away the good bacteria that are supposed to live there. I think that you really should not undertake anything that is excessive without really good advice from that standpoint. And again, I would be very suspect of those types of things.
Right. So, Dr. Keroack, I'd like to go back to a couple of these things just for a minute if we could. And first of all, it's sort of an overarching question. Is there a difference in achieving good colon health between men and women? Should men and women do things differently?
Not necessarily, because the risks of colon cancer are about the same for men and women. That's a misconception a lot of women think. I think they think it's a man's disease, and it's not. It is just as prevalent in women.
Okay. All right, good. Well, thank you for getting that out there. Low doses of aspirin, 81 milligrams, baby aspirin, right?
Yep, that's the one that has the most effectiveness and the least risk of bleeding in the intestinal tract.
Okay. And do we know why, or does the study just correlate better incidence of colon health with that low dose? And again, I would caution people, don't just start taking this. Talk to your doctor before you do.
Exactly, because if you've had ulcers, you may not be somebody who can take aspirin, but it would be an important thing to do. Aspirin blocks a certain chemical in the body called cyclooxygenase. You may have heard of a group of arthritis medicines called COX inhibitors or COX-2 inhibitors.
Yes.
That is that chemical. If you look at it in certain staining of tumors, lights up in a lot of tumors and polyps.
Okay.
So if you can block the effects of that chemical, sometimes you can block the effects of polyps and tumors forming in the colon.
And Dr. Keroack, what's the chemical again? Because I'm not going to be able to pronounce it.
Sure, cyclooxygenase, COX, COX they call it.
Cyclooxygenase.
Yeah.
Oh, I actually did it.
Look at that.
Very good. And one of the other things that you mentioned as a way to achieve good colon health is a high-fiber diet, and you mentioned fresh fruits and vegetables. Fresh fruits and vegetables can be expensive, and some of us that can be a barrier to eating such things. What other sources of fiber are there? And is there a fiber supplement that can imitate a fresh fruit and vegetable?
Well, as a side note, I heard something interesting on the radio several months ago that frozen vegetables are actually possibly more fresh than fresh vegetables, because a lot of them have been sitting there in the market for 3 or 4 days, and the frozen vegetables are frozen fresh, so actually you can get away with it with frozen vegetables. And
interesting.
That's what I thought that was pretty interesting, too.
And frozen vegetables are not, relatively speaking, are not that expensive.
Not as expensive as the fresh ones, you're right.
Sure.
I mean, certainly, local farm stands are the best, but if you go to your local grocery store, believe it or not, according to what was, and I sort of makes sense, I guess, from that standpoint.
Right.
Fiber supplements, again, it's more of a synthetic thing than a natural thing, but if it helps keep your bowels regular, then I would say that would be a perfectly good thing to use. They're not cheap now either because they've grown in popularity, but I think that it's an undigestible fiber. It has no, nutritional value other than just to keep your bowels regular from that standpoint.
And so fiber, ingesting fiber is a good thing,
yeah, absolutely.
Whether it's naturally occurring or not. One of the things that I don't understand, and I was hoping that you could kind of bring us there, as we're talking about good colon health, and people do think of high fiber, Dr. Keroack. What exactly does fiber do? What is it? Does it cause a reaction in the colon? Does it absorb things? What does fiber do that makes it beneficial to the body?
One thing it does is it absorbs some water to add a little more form to the bowel movements, and it sort of keeps things a little softer from that standpoint. It does provide the bacteria with some fuel to ferment, so unfortunately it does create gas, and that bothers some people. So it's not really abnormal if you have a high-fiber diet to complain of having gas and bloating, that sort of thing.
Okay.
But it doesn't do anything in particular because it's not digested by those enzymes that we discussed earlier. It basically just travels through the intestinal tract and is almost sort of a street sweeper along the way.
Okay. All right. So that's really what its intent is.
Yeah.
Okay. Very good. And liquids, water, it would seem would be important for good colon health as well?
I would think so. It certainly helps keep your bowels regular because it's so effective at absorbing water that if you cheat yourself on water, you'd have a tendency towards constipation, slow, difficult bowel movements, that sort of thing. And it really does help with digestion because we're basically our whole bodies are made of so much water that we really need water in our system. And a large amount. We really should drink a fair amount of water on a regular basis.
And there are people who, Dr. Keroack, who will avoid water. Some people just don't like water, right?
Yep.
So liquids in general, beneficial, or do you really try to steer your patients to water?
Well, water has no calories, right? And we're really worried about calorie intake these days. Yep. And so I do sort of say that first. Other fruit juices and some of these other diet beverages have things in them that may not necessarily be good for our intestinal tract. I'm always suspect of chemicals we put into our system, especially, artificial sweeteners and things like that. And I think that nature knows best, and water is probably your best choice from that standpoint.
Okay, because Scott tends to drink a lot of coffee.
Well, water and coffee.
and
coffee, they're always trying to give coffee a bad name, but every time they study it, it only shows good things. It's like good for prostate cancer, good for pancreas cancer. It's good for a million different things. So,
and is there anything about coffee, in your opinion, moving away from maybe the colon, but in general, is there anything about coffee that's harmful to the digestive system?
Not that I know of. And like I said, each time they try to find something bad, all they do is find more good information about it.
That makes me very
I know.
That makes me very happy. And the people back in the office are probably listening. So, Dr. Keroack, we've only got a couple minutes left, and you've done a really nice job articulating and talking about colon cancer, signs, symptoms, treatment. What is your general advice? We've talked about good colon health, but what is your general advice to folks as it relates to proper colon health and colon cancer?
Mostly keep your weight down. Don't smoke. Have high amounts of fruits and vegetables in your diet. Try to avoid fat and red meat. You do need some red meat once in a while, but not excessively. And the most important thing is I would just plead with people to please come get a colonoscopy. Every month, every few months, I sit in my office and I see people who put it off, chose not to have it done, and now they're going down a very, very dangerous path. They have cancer, they're going to need surgery, and a lot of these people are at a point in their life where their kids are off, finished with college, people are getting married, they're in their 50s and 60s, and you say, gosh, if you only came and had it done, then you'd be able to enjoy the rest of your life the way you want to. You've really got to come and have this done.
Right, yeah. I mean, it's very important. As I said earlier in the show, it's not embarrassing, it's not painful. People talk about it at cocktail parties, right?
Patients told me that the prep is not as bad as chemotherapy. You've really got to come have it done.
There you go. That's a great way to end the show. I do hear the music in the background, but the prep is not as bad as chemotherapy. Thank you, Dr. Keroack. Sound advice. Folks, Dr. Myles Keroack, Elliot Gastroenterology at River's Edge, has been in this morning to discuss colon cancer awareness. Thanks very much for listening. You've been on call with Minuteman Health. Make it a great week.